Morning everyone, welcome to this board meeting of NHS Direct, NHS Trust. We are going to have an hour of corporate board, then we're going to be splitting up into the subcommittees through which we are currently running our business. We have no apologies, except for the fact that Louisa is on the phone, so we can't see her, but she's here. And we have quite a full day today with committee meetings and things happening, so it's going to be a long day. I'm going to keep the pace up if I can. And if people who are with us online, because we're streaming live as usual, or watching us afterwards on YouTube, wouldn't mind completing a feedback form, there is a new survey for our online viewers, which we would be very grateful if people could take 5 minutes to fill in, please. I've had no declarations of interest. If anybody would like to make one now, they're very welcome. Yes. Well, as it is we are in the process of transition, as we know. There are milestones all the way along this process. There are a couple of milestones which I think are well worth it. One is Trevor Smith has been appointed as substantive Managing Director of Future NHS Direct, which is fantastic. And as a result of that, Janet Dunn's taking over as Finance Director of NHS Direct, so that Trevor can devote himself fully to the new business. Thank you for reminding me. There will continue to be important milestones and people changing roles as we go along, so we'll have those in the next board meeting and the board meeting after that, which is fantastic to see the new organisation coming into becoming real. Let's then look at the minutes of our December meeting. Are there any comments for accuracy? Okay. Then let's look at the action log.
They're all closed.
These are all which were closed. I think there was a question though. Excuse me if I've missed this being picked up somewhere else. But 6.7 on the minutes, there was a question for Tricia about why we had a dramatic improvement in call review quality. And you were going to...
Yeah, and it's in the comments on the updates on the action log. Okay, so it was an accumulation of us reviewing the core review tool. So we stopped counting the double penalties when somebody hadn't done something correct in the first part of the core review. We were doubly penalising them further down the review. Plus, we also changed our scoring to benchmark ourselves against other providers, such as antivirus providers at 60%. So it was a combination of them both.
So it's an artefact of the way that we measure rather than an underlying thing. Yeah. Okay, fine. Thank you very much. So we're now into the performance section of our agenda. First item being Chief Executive's report.
Okay, I have 3 relatively short items, but I think they're each of them noteworthy. The first, which I don't know whether Tricia would like to talk a bit more about, in terms of the accreditation that we've received from NICE and NHS Evidence for our the methodology that we use for collating the evidence that underlies, for example, the health and symptom checklist.
So we've always been proud of the processes and the governance we go through in developing and monitoring our clinical content of any of the systems NHS Direct provides. And as a consequence, NICE were developing this accreditation process. So we undertook the opportunity to demonstrate the processes and the governance we undertake when developing our content. And as you can see from the report in front of us, we were one of the first providers to be given the accreditation, and you can imagine the team are absolutely delighted with being one of the first, and it validates the efforts and the governance processes we go through to ensure we deliver safe services to our patients.
That's fantastic, because we should all be really very, very pleased with that.
So presumably there's a stamp that we'll be able to put on
even
things.
a certificate, no doubt.
Put on the
which we'll be able to put on.
Which is great. Okay, the second item's relatively short, but just to confirm that through Ruth we've agreed with the Department of Health, and it is the Department of Health rather than the NHS Commissioning Board, our continued role in managing the National Pandemic Flu Service as a contingency throughout 13-14. So that's come into place.
Very good.
And then the final one, which I thought was worth picking out as a specific on performance over the Christmas period, Christmas and New Year period, our Commissioner had been specifically had raised with us, could we undertake to put in additional nurse assessment to prioritise the use of our nurses, particularly to reduce the impact of A&E on A&E and 999 referrals. And what you can see here is the graph that very adequately demonstrates that we achieved that over the Christmas period.
Very good, thank you. Yes?
Just a question.
Yeah, absolutely.
And I don't quite understand why the red, I don't quite understand the graph actually.
Okay.
Why the red one is high between the sort of 10 to the sort of 17 to 16.
So what
it comes down?
What this demonstrates is that before we entered into the Christmas and New Year period, the level of the red graph, which is A&E referrals, was at the level it was. It varies by day of the week, so you would get more A&E referrals, for example, as a weekend than you would for the rest of the week. So that's why it bobbles around a bit. But then, as we put the revised arrangements in place on particularly the 17th or 18th of December, it comes down to the level that we then maintained throughout the Christmas and New Year period, because we put in measures to route more calls to nurses who were patients who were more likely to be referred to A&E. So we took specific action and to prioritise the use of nurse time for those to try and prevent A&E attendances over that period.
Why is that made a permanent feature?
Because it's a feature of how many nurses you have and how you prioritise them. So in the normal course of it, so effectively we took nurse time away from more routine patients in order to particularly prioritise A&E referrals over that period.
Well, my question is, sorry.
So Nick, was there any, what were the other consequences then of moving on? So did more patients get referred to GPs, for example?
Actually not, interestingly, because I think there was a similar shift. It, I think, will have impacted on the number of patients given self-care advice. So ultimately, we prioritise the use of our nurses towards the more acute end of the work. Now, the answer to your question, I think, Steve, is commissioners, consider this an advert, commissioners could decide that it was good value for money with a good return on investment to purchase additional clinical assessment time from organisations providing 111 in the future in order to have precisely this effect, not just over Christmas and New Year, but permanently. That
so Nick, have we ever shown this so clearly before?
Well, maybe not. Maybe we haven't shown it as clearly before, but it's a pretty good, that's why I brought it out today. I don't know whether I'm hogging it.
It would be easy to do an ROI on it, because, wouldn't it? So it would be a very easy thing to do, and you sort of feel almost obliged to, one would be almost obliged to make sure that everyone knew this.
Trevor, do you think we could use that in our marketing for?
I think we certainly can, and we have got an ROI that we work on based on outcomes and savings for the service. So I think it's certainly something that we can develop and play through our regional directors and into local commissioning groups.
I was going to go a bit further than that, John. Actually, I mean, the second piece of information, the Christmas period. I sort of feel a learned article coming on in a journal, and I don't know whether we've got plans for that. But I think our new commissioners who have placed their trust and awarded 111 contracts to us, I think they'd be really interested to know that, one, that we're accredited by NICE, and we wonder whether some of the others aren't. And I think they'd be really interested to know that they've contracted with an organisation that can actually help them manage their demand. How are they going to find out? And I think we ought to put some thought into that. And that isn't advertising. That's just managing the profile that you've got in the marketplace. I'd strongly recommend it.
So there's an action there, which is to, I think that's probably an action for Ruth, Trevor, Ruth and Trish, to think how we use this new insight to help commissioners make value-added commissioning decisions.
Yeah.
Great. Thank you very much.
Okay, could I have
And you
one?
don't think, sorry, just briefly, oh no, don't worry, carry on.
No, I've stopped, Louisa.
I think Louise
No,
has
I just
got
wondered, this is so fundamental, isn't it? And there's so much concern about this that you sort of think that somebody at sort of commissioning board level, at national commissioning board level, should probably sort of, whether there's any conversations we could have there.
I know, well, first of all, we had a conversation with Paul Watson before Christmas about the 0845 service, and I know that the potential for return on investment from additional clinical assessment is recognised at that level, and I think the action that the board's agreed through Trevor and Ruth and Tricia is the right one.
Yeah. Okay.
Okay, can I have one AOB to my chief exec's report?
Yeah,
is that
please.
possible?
Yeah, please.
So just to report that we had what I thought was a very interesting and useful seminar on the 23rd of January, so last week, concentrating really on reacquainting ourselves with the first Francis report and indeed the other 6 reports that have been compiled on mid-staff since the original Francis report came out a couple of years ago. It's obviously in anticipation of there being a further Francis report coming out sometime in February, we understand. We looked, we had very useful input from Paula Higson, who will be known to many of those around the table here, who's been doing part of her PhD thesis on the implications from mid-staffs alongside other things. And what it gave us the opportunity to do for a couple of hours is to concentrate on those things that, in addition to what we're already doing, we ought to think about and concentrate on going forward. And there were about 5 or 6 clear issues that came out of the discussion, which we're just going to sharpen up a bit, and clearly they have implications for the future quality arrangements within the new organisation. So we're just going to kick those around, and I'm sure that they will come through into the future organisation in some way, shape or form.
Thanks, Nick. I mean, there's an opportunity. We've had seminars in the past. There's an opportunity for board members to spend more time in a less formal context, delving more deeply into specific issues. It was a good one to pick. Obviously, when we timed it, we thought that the second Francis report would be out, and it's not. But it was still extremely useful because we revisited the underlying issues, the things that went wrong within the trust, and thought about some of the things that we might do to ensure that we're providing a safe and effective service. So it was very useful. Thanks, Nick. Okay, shall we, just before we move on to the performance package, just check whether anybody else has a question or comment for Nick. Okay, let's then move on to the performance pack. So as usual, we've got operational and financial performance, and Trevor will introduce both.
Me today.
Oh, Jackie was. Okay.
Yeah, I will have a go at following Trevor's footsteps and introduce them both. I'll introduce them both together rather than separately. First of all, starting with the corporate performance. I've just sort of stood back, looked at the scorecard and thought, what do I think of the performance for December? I think overall, generally quite good, considering it was December and it's the Christmas period, and I do remember the sort of Christmas of 2010, which was pretty awful. So I think it was pretty good. Patient satisfaction remained high, and I was pleased to see that in clinical access all targets were met for the month. There may have been the odd day when we didn't meet, but we did meet the targets for the month. General access was down, but that was generally just, we had a couple of very poor days on the general access, but for the rest of the month it was pretty good. So we did fail access, but not too bad for the period. As Nick referred to earlier as well, we did manage to satisfy the Commissioner's request to increase the number of sort of nurse referrals, in particular to try and reduce A&E referrals, and it looks like that worked. So it's about 5,000 attendances saved. So again, very good. Call volumes were down, largely because it was a mild winter, and that obviously helped to improve the performance. From the financial point of view, again, fairly good news. We're just slightly ahead of plan. I do, however, have a couple of issues on finance which I do feel like I need to bring to your attention. The first one is, whilst we're ahead of plan, we have got a year-to-date deficit of just under £1 million, and that is very different from where we usually are. I look back at last December and we were at 2.6 million surplus at this time of year. So we are in a very different position. We knew we were going to be here and we knew it was going to be difficult, but it does mean we've got less capacity to meet with some pressures. A couple of those pressures are now starting to emerge, so we've got a couple of risks starting to turn into pressures. I think with careful management we will be okay, but we know that we're heading to a February and a March which is unprecedented within this trust. We've got double running costs, we've got people going out of the organisation, people coming in the organisation. So if we do get any more pressures, there is a risk that we may have a deficit. But at this stage, we, as I say, with careful management, we should be okay. But I just thought I ought to bring that to your attention. Any questions?
Thank you, Jackie. Yes, there's some questions and comments. So there's Steve, then Peter, then I'd like to. So I tell you, I'm just thinking before we get into that, could we just divide the conversation into operational and financial? So if your points fall into one or the other. Steve, are you operational or financial?
Financial.
Peter?
I had one small point on operational, and if Steve covers it, the other one was financial, so he may cover it.
So can we have your operational point first?
I've got an operational point, please.
Okay, so and I have to. So we'll do that, and then we'll come back to the financial point if you'll bear with me. So Peter, your operational point, and then hold your financial point if you wouldn't mind.
I just wanted to comment on the sickness, because although there's been an uplift, I was quite intrigued that in fact both in the long-term sickness and short-term sickness, we were still performing better than we have in previous years. And I thought that was important. I mean, I recognise that, and perhaps the difficulties, and I assume, I mean, the vigilance is mentioned in here about what's going on, but I just wanted to say that. And the other thing was, with regard, I think there is I just want to say on 6 of 11, schedule of adherence, it should be December, I think, rather than in the mid B15. So that's just a correction. Thank you.
Thanks, Peter. So sickness position deteriorating, but still better than we've been in previous years.
And previous month as well, I think, as also.
Tim Hayman, do you want to come in with your operational point?
Yeah, I was just trying to reconcile the shortfalls in performance, particularly around roster efficiency and scheduling adherence, with probably I don't understand the staffing numbers correctly. The 55 variance is a negative variance, so there are 55 fewer staff than we should have had, than we scheduled to have. Is that correct?
Yeah.
Which would explain some of the problem, but it's only a sort of 2% type issue, and we seem to be well off on, much more than 2% off on our call answering and schedule adherence and roster efficiency. I just trying to understand which of the areas we were less good at sort of predicting. If that's the right word. What?
How do you triangulate those three things? Yeah. I suspect that the answer is the impact of the number of people being taken offline in order to be able to go through the training that's necessary for the preparation. And I think that's what's caused the three not to quite be as triangulated.
Absolutely.
Okay.
That was certainly the case when I looked into that last night.
It is absolutely the case. We have had to move in real time with everything we've going on with the training, with the mobilisation. It has caused us to fall short and fall foul a little bit of our rostering efficiencies on that.
And can I just follow up with another question then on the staffing side, which is that with the other staff, full-time equivalent, the variance is large, although the overall numbers are small. I just wonder if that's just a timing issue again as we transition. It seems like that.
So we're short on other staff.
No, we seem to be excess on other staff by 30%. I don't know what these other staff are, but.
And you're looking at that's in the financial.
Yeah, it is the financial. I'm sorry.
Can we take that offline, because I'm not.
Okay.
I'm not sure that we can extemporise an answer on that.
Okay.
It sounds like I don't feel that we've got 30% excess of anything.
Well, indeed,
So,
it does seem very odd. It does seem odd. So it's probably an account.
Yeah, I think it's
long term, but.
So we'll come back on that.
Yeah.
Okay. And then Tim.
Thank you. I had a question about roster efficiency, but I'll join in on that. Looking at page 4 of 11, the abandonment rate, I was struck by how much it had moved. Is there any further anything you want to say about it? It's just we've been well under the target, and it sticks out like a sore thumb.
Yes, and I think in the main that is due to the pinch points that Jackie mentioned throughout December. For example, 22nd and 23rd of December was basically felt like Armageddon slightly in the contact centres, and where we abandoned a much higher percentage than we would normally do. So we only answered those days on the Saturday. It was a Saturday and Sunday, and we were over forecast. The weather had hit as well with snow around various different regions, so we had a shortfall of staff. So everything hit us that weekend. That's just one example. There were a few other days throughout the main hit dates in December. For example, we were just at 16% that day, answered in 60, and we had a high abandon rate.
Wow.
So that actually brought it overall to the month to the 8%, but on most days it was.
Okay, so it should be much better in January.
It will be, yes.
I'm going to follow up there, because I was also trying to reconcile that. And so I was looking at, it looked like we were 200,000 people down on where we were expected to be in December. So I'm looking at B16, or the contract said 550,000, and we actually served about 350,000 people on the phone. So there's some 200,000 theoretical people who didn't get through to us. And I looked at that, and I looked at the symptom checklist, and that looked as if we may have picked up an extra 50,000 people who were maybe being served online who weren't on the phone. But we had 11 days when the abandonment rate was above 5%. So that, I guess, is where those people were. Yeah. They were trying to get through to us on those 11 days when our abandonment rate was above 5%, and we weren't able to serve them. So, I don't know, does that feel right? Was that what was happening, or were we just?
Or was it contract?
It was contract. Was just wildly over optimistic about.
If you look at December 11.
Yeah.
Why did we end up with such a huge contract volume?
Whereas December, well, I suppose we thought that in December,
because December 11 was a bad year, wasn't it?
Well, December 11 wasn't too bad. It was December 10 that was really bad. I think the plan was set as if we were going to have another December 10.
We clearly just didn't have the capacity to deal with anything like 550,000 votes.
But I think, just if I can pick up the potential implication of what you were saying, was that 200,000 people called us but didn't get through. Yeah. That isn't what this shows. What this shows is what the contract provided for by way of financial underpinning, and that which we were able to deal with, and the difference between the two. So it's not that there were 200,000 people.
No. I agree with that. Okay, so if we're going to finish off this, is this the same point? And then I'm going to come to Sue, and then we're going to go back to Monday.
I just support Nick's view there. I mean, at the same time as we were falling far short of contract in terms of volume, the number of any attendances were plummeting.
Yeah.
So we must have been doing the right thing somehow.
So, is the operation?
It is. And also, I think this is the only, or maybe I'm wrong, I think this is the first year I have sat in the board looking at December Christmas performance and that we've actually met all three of our clinical urgent, less urgent and non-urgent calls. I don't think I've sat here and seen 96%, 96%, 96% before, ever at Christmas. So it feels a little negative, this conversation.
Yes.
I actually think it's really, really positive, and I think the organisation should be absolutely proud of itself in terms of how it's managed to deal with the performance over the Christmas period.
Very good.
I think Sue's hit the nail on the head, and I think we should recognise that by expressing our thanks to all of the staff for the efforts over Christmas. 5,000 fewer A&E referrals is very significant for the rest of the NHS. Huge success.
Yeah.
And meeting all of the targets that we have in terms of access.
Very good. That's a good note to end the operational discussion. Peter, you had a finance point? No, shall I go?
Tricia was trying to.
Yeah, I was just trying to add to that final comment, Joanne, thank you. On B20 and B22, page 8 of 11. So not only did we support the reduction in A&E referrals, we also met our target for our 0845 callers completed within the organisation. So we supported the health service at both ends of the spectrum. We supported patients to stay and remain in their own home and care for themselves, as well as reduce the A&E referrals. Thank you.
Very good. Steve, we'll come to your finance point, if you can still remember.
You mentioned that we have a deficit at the moment, and we could well end up the year with a deficit. What's the implications of that?
The implication, we would have a deficit for the first time, which I don't really want last time. Now finance director, so we would be doing everything we can not to have that. In terms of our break-even duty, it's unlikely to have a significant impact on that because we have a 5-year break-even duty, but we've got previous 4 years of healthy surpluses, so we will not break our 5-year break-even duty, so that is good news. But clearly we will be on some sort of radar as the trust in deficit, which we wouldn't really want to do.
You can.
The expectation would be, Steve, that we would make good that deficit, were there to be one, from future years, and that has to be within the next 3 to 5 years.
Well, that's with a new organisation, so that was That was going to be my concern.
So the clear intent, the forecasts, and the position that's being managed at the moment is to achieve break even or better, which is in line with what the forecasts are.
Yeah.
Can we not offset previous surpluses?
No.
It's a 5-year rolling programme for the break-even duty is a 5-year rolling programme.
Sadly,
Clear about that, Pete.
Sadly not. Well, if we were a trading company, I agree with you, but.
Okay.
Can I?
Yes. So Peter had a point. And
I just want to follow up. I mean, I think it's quite clear that the good news is having identified this now, we still have a period to get it right. It does appear to be in pay rather than anywhere else, as far as I can see, which isn't so easy sometimes to deal with. And I mean, I would caution against us having any significant deficit to take forward, both a reputational, but I mean it's just also it comes out in the final our annual reports and in the financial statements, and we just don't need it. And I'm just feeling for you, but I think we need to ensure this does not happen.
Yeah, so what we're supporting you, Jackie, because we've heard what you say, it's within plan, the expectation is we'll be break even with at the end of the year, and we support whatever measures you and your colleagues decide to take in order to make sure that we hit that.
Yeah, correct.
Okay. So Sue, then Nick's going to finish the conversation.
I would echo what you just said, Joanne, but I would also say this is extremely complex what you're trying to do in terms of trying to manage the various buckets of money, current performance, plus decommissioning, transitioning, and I really just wanted to echo the support. We had long discussions with the finance committee, and this is not an easy thing to do, so it's sort of support really more than anything else.
Thank you.
Great. Nick.
Just to add my perspective on it, I just pick up Steve's use of the words may well end up with a deficit. I'm not sure that's well, certainly that's not my understanding. What Jackie was doing, quite rightly, was raising a risk. I think it's not a high probability, and I'm quite clear that yes, in amongst the, I wish we did have buckets of money, but I know what you mean.
No, yeah, you're right, Tammy. Classification. Not good terminology.
But you know, yes, this is complex, and we are managing the decommissioning activity as well as the mobilisation activity, and running existing services and preparing for the contingency. So there's a lot of juggling being done. But I'm absolutely clear that we will do everything that we can do to live within our means this year and come out with a surplus as planned, and I'm confident that we'll do that.
Good.
I replace may well with may possibly.
Yes.
Yeah.
I would agree.
Thank you, everybody. Then we'll move on into governance and compliance. Roger, we have your paper on staff. Thank you. Your very welcome update on staff consultation requirements. We can take that as read, I think. Are there any particular points you want to underline for us, or shall we go straight to questions?
Straight to questions.
Okay, that's great. Do we have any questions for Roger on the process of the transition that he's described in staff consultation? Trevor?
Just a comment. I think I was very pleased to see that we have a very mature process. Understandably, there are tensions between us and the staff side at a time like this, but the mature relationships, I think, are to be welcomed.
Yeah, good. I'd echo that. Fine. So there's nothing you need from us, Roger? On
Nothing at all on this. This is a progress report only.
Okay, good. Well, thank you for that. Sarah, Board Assurance Framework.
Thank you.
To you.
Okay, the Board Assurance Framework has been reviewed and updated by the executive team. We currently have 12 amber objectives on the framework, mainly for reasons that we discussed throughout the performance report update, and we do have a recurring theme throughout some of our objectives, and that's mainly to do with our capacity, and it's our training capacity, because we've got a lot of staff coming into the organisation that need training, and also as we convert staff to use the pathway system, we also have training implications there, and we also have to increase our training capacity within the organisation. So training is impacting a lot of our corporate objectives at the moment. The Board Assurance Framework has been to the Audit Committee, and they have scrutinised the framework, and I'm happy to take any further questions.
I just observed that we always knew that decommissioning one service and transitioning into a new one creates a lump in training, because we're...
I'm so sorry to interrupt. I'll just tell you I have to leave the call now to go to my...
Fine, Louisa. Just give us a shout when you're obviously log back in. Just turn this off. So, I mean, that is an inevitable cost and consequence of changing from one service to another. I know that's caused the executive quite a lot of anxiety and effort to get that right. So I don't know whether Trevor or Nick, you want to just tell us where we are on that training issue, or...
I think in terms of the overall training, we have a further report which I think we'll discuss in the private part of the meeting. But in overall terms, we have a small shortfall this week, and we're looking to, but compared to where it was, we would be predicting 2-3 weeks ago, we've closed the gap significantly, and so I'm confident that we will be able to train the staff that we need. I think in terms of mobilising the new 111 services, I'll hand over to Trevor to talk about that.
Yeah, I think what it's shown is some of the complexities around the transition that we've had to go through, the careful planning that's been required, ownership of the training plans, and clearly now careful management to make sure they're implemented fully.
Thank you. Any questions for Sarah or any other members of the executive on this? Okay, risk register then.
Okay. Again, the corporate risk register has been reviewed by the executive team and updated. We currently have 8 entries on the public section of the register, but we don't currently have any red risks on there.
questions, observations on the risk register? Trevor?
I just have one. We have listed as a risk in the Department of Health Enforcement Cabinet Office guidelines. I'm not sure that that is a risk for NHS Direct. It is an issue between the department and commissioners, and I don't think there is any knock-on effect for NHS Direct if the cost of redundancies rise. I'm just checking that that is the case. I think the risk lies with the department. If it all goes wrong, the department will need an extra cost.
I agree that's true in financial terms, but one of our objectives has been to enable as many of our staff to be placed with other NHS 111 providers, irrespective of who bears the cost of not being able to do that. We've regarded that as one of our objectives to seek to achieve through influencing others or through direct action that we've taken. I mean, at the top level, and in terms of that, is that the risk of non-achievement of that through non-compliance has gone down, courtesy of the increased grip that John McIver and his colleagues at the Commissioning Board, when they came in and took over from the DH officials, the increased grip that they've demonstrated, and I think we've seen quite substantial movement, which I think is reflected in this risk rate.
We are clear, though, that the financial risk lies between the Department of Health and the Commissioners, not to us.
Steve?
I noticed in a further report that the call volumes 111, I think it's North West contracts, are far above our expectations for the month. I just wonder whether that was a risk, because under future NHS threat there's nothing about 111 call volumes.
It's certainly one that we're investigating at the moment. So as soon as we have the results of that investigation, we'll be making a decision as to whether it comes onto the register. It's one we're looking into.
So that's the risk of unexpectedly high demand. Okay. We have a number of sets of minutes and feedback from the committees. So, verbal feedback from the 17th December, no, that's from us, Trevor Smith.
Yes.
We did put some minutes in.
There are minutes that are public for the existing
I always get confused here. Okay, yep. So shall we have some verbal feedback first of all from the future committee, Trevor? Just a word or two.
Yeah, areas that we covered during the discussions were our progress around contract sign-offs, mobilisation, including the soft launch at that stage of Sutton and Merton, which has since gone into full launch successfully. We covered performance issues, discussed handling times for our call handlers, transfer rates for clinical advisors, and as well as the operational issues, we discussed finance, risk, and equally some strategic issues around cultures, mission and value for the organisation going forwards.
Thank you. I presume there aren't any questions on that. They're probably best sit with the minutes themselves, which are in the private meeting. Trevor, we have both minutes and feedback from the existing services in transition and decommissioning.
Yeah. Just to summarise, I think the overall position, I'd say that whilst the organisation is facing significant pressures, performance is satisfactory, quite strong, I think, in actual fact, and also is stable. And I think the committee believes that we have a well-managed process to ensure that we can maintain that. So we are pleased with the way that's going. Looking forward slightly, we're moving into the period where we will be transferring services to the new part of the organisation. I think the key issue there is to ensure that we have a very, very clear focus as far as management responsibility is concerned. When you're transferring services like that, there's also always a risk that everybody else thinks someone else is handling the issue. So I think we need to concentrate now on ensuring that we have a smooth transfer of responsibility between the transitional and existing service part of the organisation to the new, to ensure that we don't lose performance through that process.
Thanks, Trevor. Any questions, Trevor, on his summary or the minutes of the subcommittee? No? Okay. Verbal feedback, I think, from you, Peter, on the audit committee.
Yeah, thank you. Just a few things to report. First of all, on the internal audits, on the quality and safety audit, which had an adequate assurance, some of the recommendations which relate to complaints management are going to be reviewed by the Clinical Governance Committee. So Sue will be taking that on board, and so we'll actually look at the processes and to ensure that they are fit for purpose. On the board assurance framework and risk management processes, the internal auditors gave a substantial assurance to that, and I say both documents and procedures were seen as best practice, and that's very reassuring to us, and also with regard to their format and content. So I was very pleased to report that back to you. And also, as you know, the Audit Committee continues to follow up all recommendations of the internal audit processes, and I can report that there are no outstanding recommendations currently. All have been actioned appropriately. On the external audit, the main issue that came up was the treatment of the agreed funding for the decommissioning costs provided by the Department of Health. There are a series of meetings taking place to resolve this with our managers and the board here, and I know there'll be more details perhaps in the part 2 of the meeting, so we can pick it up there. I think the little sort of niggle that we've got at the moment with our management colleagues is regarding fire training. We're so close to having full compliance with our fire training. It literally is just pushing across the line. I appreciate all of the issues around operational factors that we've talked about earlier, but the Audit Committee is impatient to get this finished. We've been assured it will be. So I'd like to minute that. The second thing was the IG Toolkit compliance process is running again.
Information governance.
Information governance, that's correct. Again, we need to ensure that priority is given to this so that we can actually get across the line as we did last year. And I know Alan has...
That means you.
Alan.
Us.
It's Alan.
It's everyone.
But also I have suggested a process if the non-execs should have a particular difficulty with the online arrangements, that we have another approach which could be done today. And I'm hopeful that will be done today.
Great.
Other than that, we had a very extensive, detailed conversations about many, many matters, but those are the key points. Thank you.
Thank you, Peter. Does anybody have any questions or comments for Peter on the exemplary audit committee report back? No. Okay, good. Thank you. Sue.
We did have a clinical governance committee as well. Did you want some feedback from that?
Yes, please. I'm sorry.
Oh, is that
It
on
goes to existing
It goes to
services
existing-
first,
I guess
and then the
existing
minutes
services.
come.
What about finance committee? That's the same.
Finance committee as well, yes.
Okay. So you'll report back later in the day.
And then the formal minutes will come here for the lodging.
Sorry, I got confused.
We are in constant danger of confusing ourselves.
Indeed.
But it is working reasonably okay. So.
Yeah.
We're now in the stakeholder section of the agenda, where we report back on our interactions with staff and with and indirectly with patients. The Existing Services Transition and Decommissioning Committee on the 17th listened to Northwest 111 service calls. Does the committee have any feedback for us today on your conclusions from listening to those calls?
I think in the committee minutes, 8.2 highlights the issues that arose. I think generally we thought the call was a good call, and particularly the patient feedback was very, very positive about the call. We did have slight concern about whether there could have been more empathy shown by the health advisor. We did wonder whether the call ended slightly abruptly, but the patient was very, very satisfied, so I suspect patient knows best. We did have a concern that on the recording we could hear background conversation during the call, but we were assured that that conversation would not be heard by the caller. It's simply the way the call is recorded, so that was reassuring.
Fine. Does anyone have anything else to add? I mean, obviously the detailed conversation was had in the subcommittee. So in the future subcommittee, we were also listening to call recordings, calls which I think the other subcommittees already listened to on toxic substances, brackets congestion of, and children with fever. Tricia, would you like to just say a few words on our conclusions in relation to those, and then I might add something.
Yeah, okay, thank you, Chair. We, as the future subcommittee, reviewed the calls existing services I've listened to the month prior, and we very much scrutinised these calls with an eye on how future NHS Direct could improve its services for the benefit of the patient and also for the delivery of newly commissioned services. And the first two calls were regarding toxic ingestion, of which we felt there was lots of duplication within the assessments, which could, with future support, staff could contribute to us improving the service in order to reduce the repetitive nature of those calls. And we also felt one call in particular could have been significantly reduced with regards to a gentleman ringing up having topically applied some methylated spirits to his toe, and we believed that we needed to be more succinct and condensed in the way we assess and manage those calls in the future. The second group of calls were related to children with fever, and particularly these calls were originally audited with a view to were we adhering to NICE guidance and ensuring that our patients received appropriate care that was supported by NICE guidance, and we believe that we did that. But equally again, there was areas within the call where things were repeated, and we believe the assessments could have been more succinct. We believed empathy was demonstrated. We believe that the patients, we certainly noted that the patients all reported having a good experience, but as a provider organisation, we did all recognise that there could be some improvements with the process.
Thanks, Tricia. I think that captures it very well. Okay, thank you. This is also the part of the agenda when we feedback from visits that we've been making to our frontline contact centres. Is there anyone who'd like to talk about experience or impressions from visits? Jill, I wonder whether, I've got a note here that you've been to Beckenham. I mean, obviously executives are out and about, you know, yes, a great deal, but was there anything particular from the Beckenham visit you'd like to share?
Well, I think that lots of positives. So the agents had certainly picked up, I felt, everything within the training. So the training had gone very well. They were, as we all know, they yet to date have not received many calls. So they're practicing as they go.
So these are people who've been receiving some in the
yes,
calls?
Yes, exactly. So variable call volumes between 30 and 60 on any one day between them. So they've not yet practiced. Call control overall in the main was very good. Room for improvement, yes, in a mix of people, process and systems, which we are working through outside of this group together to get efficiencies within there. So they are not at the desired commercial AHT, with some additions to people, process and systems in time that will be achieved.
And how are they feeling about it?
They were feeling it was a mix.
Yeah.
So very, very positive with lots of things. They like the front screen. They like Cadastra overall. There were elements that they didn't like, that they felt were too onerous. And some of those onerous is out of our control at the moment, but we are looking at those. Particularly interim care at the end of the call is particularly onerous and can go on for several minutes, thus taking you way outside of your desired threat.
Oh, that's interesting, because the future subcommittee's been listening to some calls,
yes,
which exhibit precisely that, I think,
yes,
and also exhibit the effect that it has on the staff members' behaviour, which is,
yes,
I've got a lot to rack up through.
Yes, yes, it's not a great customer patient experience.
Interesting, isn't it? Okay, that's a very interesting point.
We've documented quite a bit on that to see what we can get.
So I've got Ruth and possibly Tim. Okay, Tim first then.
Well, just a brief question: to what extent can we automate the terms and conditions effectively at the end of the call? To what extent can that be automated? To what extent can they press a button and have a voice then, which will go through those worsening issues?
I think that's wonderful, and what we're in the process of doing is tracking to see how many outcomes could there be.
Yes.
We haven't got that information. There are several. We know which are the longest, which are the so we need to categorise the calls and then go into solutions. But yes, if that could be done, that would be very beneficial. I think also on a point to that, noting it is very long for a patient to recall, even if we automate it. Far too much information.
But
yeah, so there's lots of interesting things we can
Yes.
definitely do with that. Very good. Ruth.
I just wanted to build on what Jill said. So I went to see them on Christmas Eve, and I have to say that the environment felt very different to 0845. And when I talked to them about that, they said it's a long time since we've felt like we've been working as part of a team. So there's something different about the way we've set them up and the way they're co-located with their nurse counterparts, that they do feel much more part of a team now than they have done for a long time.
Okay, thank you everyone. I think we've come to the end of the public part of the integrated board meeting this morning, unless there's any other business.
thank you.
So the next meeting will be on the 25th of February. It'll be here at Lehman Street at 10:30. It will also be online. For anybody who's been watching us online, please fill in the questionnaire. We'd be very grateful if you would. And with that, I'm going to close the public part of the meeting.